Hi guys, this is Dr. Lee and hi Dr. Baby.
Hi, Dr. Lee. Thank you for having me on your show today.
Oh, I'm so excited to hear about that. I mean, truly endometriosis is something I really want to share and message out. And you are the in this area and then expert in endo, especially endosurgeon and RDI. So, can you share like the people who you are and introduce quickly about yourself?
Yes, I love talking about endometriosis, so thank you for having me here today. So I'm Sadika Bevahani. I'm a double board certified reproductive endocrinology and infertility specialist, as well as a minimally invasive GYN surgeon. So the reason why I did both training in surgery and infertility is to be able to help women who are trying to get pregnant but have issues that require surgery to help them. The biggest one being endometriosis. So I practice in Newport Beach at the Center for Endometriosis and Fertility. And I started the practice specifically to help women figure out what's going on with their bodies when they have endometriosis and they're struggling to get pregnant, and also help them feel better. So, not all my patients with endometriosis are here to get pregnant. I also help women in general just treat endometriosis. But yeah, to go back to your question about introducing myself, I'm an endometriosis specialist, and I do a lot of endometriosis surgeries, but I also do IVF and do other treatment options for fertility to help women with endometriosis conceive.
Yeah, actually, I know you first as the REI, and then later I really realized that you are
Mhm.
also endosurgeon. So, which is an amazing specialty you have. So, can you like this is a very common question, like a very basic, but what is endometriosis? And then also people kind of confused with adenomyosis or like I have a fibroid or I have a PCOS. So there's a little bit of a terminology here. But can you explain quickly to the viewer what is endometriosis and a little bit difference with the other symptoms?
Of course, yes. First of all, they're all gynecologic conditions, so they can all happen together. Are they related? Some of them may be. So let's backtrack a little. What is endometriosis? Endometriosis is when tissue similar to the tissue that lives inside the uterus travels outside the uterus. It could be around the bladder, the bowel, behind the uterus, on the ovaries. It could be even up on the diaphragm. Endometriosis can grow anywhere. The reason why it's important is because those implants, every month you're on your period, bleed and they have nowhere to go. So the blood gets trapped in the tissue. That creates scarring and fibrosis and can cause a lot of pain. So oftentimes women with endometriosis have pain with their periods, pain with ovulation, pain with intercourse, pain with bowel movements. It could be any different type of pain. But you asked about the other conditions. Adenomyosis, for example, often co-occurs with endometriosis. Because what adenomyosis is, it's when that lining of the uterus travels to the muscle layer of the uterus. So now it's not completely outside like endometriosis is, it's still within the uterus itself, but it's in areas where it shouldn't be, which is the muscle layer of the uterus. That causes the uterus to look swollen, look enlarged, and that can create a lot of pain and heavy bleeding. It can also affect fertility. So when we're trying to figure out what's going on with our patients, we want to look into both adenomyosis and endometriosis and figure out if the patient has both or has one or the other, because their pathophysiology is very similar. Now,
Mm-hmm.
fibroids is a different story. They may actually look very similar to adenomyomas. So fibroids and adenomyomas sometimes get confused and it's hard to separate one from the other. Adenomyomas are adenomyosis, but in round bundles, so they look like a mass. And fibroids are benign tumors of the muscle layer of the uterus. So sometimes, and I see that often when they're getting ultrasounds or MRIs with radiologists, they misclassify adenomyomas as fibroids because fibroids are more common. We see fibroids all the time. But to me, being a surgeon, it is very different when I have to treat them surgically because fibroids are easy to remove, they're common, they're everywhere. You open up the capsule, you peel off the fibroid, you suture the uterus closed. Adenomyomas are very sticky. They don't have great borders. You don't know where the tissue is healthy, where the tissue has disease. When you cut it out, it's like cutting a chunk of the uterus out. It's hard to close. So I always tell surgeons it's very important that you determine what type of surgery you're walking into. Am I doing a fibroid removal or am I doing an adenomyoma removal? Because the technique can be different. Now, in terms of symptom presentation, fibroids can also cause pain and can cause heavy bleeding. But fibroids are a lot more common and easier to treat than adenomyomas. You also asked about PCOS, polycystic ovarian syndrome. PCOS is a whole different story. And what I always like to remind women is that PCOS does not cause pain. Okay, so I'll repeat that again. PCOS does not cause pain. So if you have painful periods and you're told it's because you have PCOS, that is not true. There has to be something else causing your pain because PCOS is a important GYN condition. It can cause
Mhm.
infertility, it can cause lack of ovulation. There's a lot of insulin resistance, so women may have issues with weight, but it should not cause painful periods. If you're having monthly periods and you have pain with your periods, we need to talk about what else it could be, and most commonly, it's going to be endometriosis.
Hmm. Very, very good insights. So now, since we know all different conditions, so what are the early warning signs of this endometriosis that the woman often told is like a normal? Like maybe, for example, it can be just pain, like just pain, like how severe it is. So, but it shouldn't be ignored. What is the early warning sign?
You know, I hate it when people tell women that it's normal to have pain with their periods because they are absolutely delaying diagnosis. It is not fair to this woman who's suffering and struggling every month on her period, being told it's all in her head, or you'll outgrow it, it'll get better with time, or just get pregnant and it'll go away after
Oh,
pregnancy.
that's horrible.
It is not fair to this woman who's struggling to figure out what's going on with her body. So, pain with your periods is a big indicator of endometriosis. And actually, I have patients who are 13 and 14 who come to see me because they're having pain with their periods. And I'm sure most of patients who have pain when they're older, it started at a young age. So, what I always tell my patients is listen to your body. If you're having pain with your periods, that is not normal. It does not matter how old you are. You could be 12 or 13, or you could be 50 and still having pain with your periods. What's important is for us not to ignore it and just classify it as normal and telling women they'll outgrow it because they oftentimes won't. Women with endometriosis have symptoms at a very young age. Most of my patients who come to see me, they're in their 20s or their 30s or their 40s. And I always ask them, how were your periods when you were young? Did you have to miss school because of pain? And most women say yes. I had to miss school, or I wish I could miss school, but my mom said I had to go. Some of them say I had to go to the nurse every time I'm on my period because it hurt so much. So that's one early indicator that something's not wrong, is something's not right, something's wrong, is if you're having pain with your periods requiring you to miss school because of the pain. Not everybody is going to have symptoms at such a young age. Some women are fine, and you and I have talked about it until something triggers the pain. And we don't know what environmental factor it was. Is it inflammation from something else? Is it a disease? Is it a stimulus? But something happens where periods were fine and all of a sudden they're not. And it doesn't mean the endometriosis grew overnight. It's probably been there for a long time, but sometimes it's dormant and quiet until something triggers it to flare up, and all of a sudden the pain is substantially worse or new symptoms start to arise. But early signs that you should not dismiss are pain with your periods, pain with sexual activity.
Mhm.
Sometimes patients attribute it to, well, it's a new partner or I haven't had sex in a while. But if you consistently are having pain with sex, that is not normal. If you're having bloating on your periods, pain with bowel movements, diarrhea, constipation, that's not normal. If you're having bladder symptoms, frequency, urgency, pain when you urinate, that's not normal. And not everybody is going to have all the symptoms. Not everybody is going to have pain with their periods, pain with sex, pain with bowel movements. Some women may have just one of those symptoms. But if they're consistent and they're always worse around your period or ovulation, then that's a trigger warning that something's wrong and it may be linked to endometriosis.
So all these conditions in the pelvic area, but it's related more towards a period, and then it's just recurring, and then it gets severe. That's a very good time to check and know what it is. So now that question here is, so is it endometriosis primarily hormonal or inflammatory or even like immune related or all of the above? Because there's a lot of triggers here.
Mhm. All of the above for sure. It's definitely an inflammatory
Yeah.
condition. So women with endo have lots of inflammation, not just in the peritoneal cavity, but everywhere. There's a lot of generalized symptoms that happen with endo. So fatigue, brain fog, headaches,
Hmm.
anxiety, and mood disorder. Those are very common in endometriosis patients. Endometriosis also often co-occurs with other inflammatory disorders, with other autoimmune disorders. So we see a lot of mast cell activation syndrome, Ehlers-Danlos, POTS, postural orthostatic tachycardia syndrome, all of that, those unusual, poorly understood, not readily diagnosed disorders also co-occur with endometriosis. And so that's why sometimes I'm the first person those patients see with those symptoms. They tell me, oh, when I'm in the shower, I lose consciousness. I need to quickly take a hot shower before I faint. That's not normal. Or if they say, oh, when I'm in pain, I break out in hives. That's not normal either. So I kind of help direct them to other specialists, but I can't do it all myself because, like I said, my training is fertility and surgery, and I'm not the best person to see for postural orthostatic tachycardia or POTS. I'm not the best person to see for MCAS, but I listen to my patients and, trigger warning signs go off in my head, and then I help refer them to people who need to see them. So I always say treatment of endometriosis is multifactorial. It is multidisciplinary. It's me, it's you, and it's other specialists. We all have to help out in the field we are experts at, and we can't ignore the other symptoms that are happening. We just need to redirect women to who else can help them. Because to answer your question, it is inflammatory, there is an autoimmune component, and it is also environmental. I see a lot of women sometimes with, for example, mold exposure, and they say, I was
Mhm.
feeling fine until I lived in this apartment. There was a lot of mold. I was tested for mold, and now I'm in pain all the time. I have neurological symptoms. So this might have been the trigger. Endo probably was there, and the mold exposure, the environmental toxin, triggered it to grow. What's important to me is to help my patients feel better. And that's what I tell them. When I see them, we go over all their symptoms. It's a detailed consult because I have to ask about all those other symptoms, not just my GYN symptoms. But then I tell them my goal is to help you feel better, and I can't do it alone. I will do my part, and then we'll reevaluate and see what your symptoms you still have, and then I'll send them to other specialists to help undo the damage that has formed from the endometriosis.
So it sounds like you are REI. So if this patient is not trying to conceive and then they coming for your surgery and then you find another practitioner to involve in the lifestyle medicine. So you actually, they continue see you after surgery or you usually hand off patient to the another doctor?
So my favorite patients to see are the ones who are not trying to get pregnant yet, because then I can help them restore the anatomy. I
Hmm.
see a lot of young women, right? And no one knows that at 17 and 18 and 22, they're not thinking about pregnancy. They don't know when they want to have kids.
Hmm.
But it is absolutely essential to preserve all their fertility organs and
Hmm.
remove the endometriosis in a manner that doesn't damage their potential to get pregnant. Because let's talk about endometriosis and fertility. Not everybody with endometriosis has infertility. 70% of women with endometriosis get pregnant naturally. And that's a very important number because then I have women who come see me and say, but I had two kids. Do I really have endometriosis? Yes, you can still have endometriosis even after you've had children. Pregnancy and childbirth is not a cure for endo, it's not a treatment plan for endo. And women who have endo can still get pregnant naturally. So I like to see women before they're actually struggling to get pregnant because sometimes they come see me. It's been 3 years, 4 years, 5 years. They're 40, they're 41. It's a lot harder to treat. But when they're young, we are setting them up for success. I can treat all the endometriosis, excise it, restore the anatomy of the ovary and the tubes and the uterus, and still allow them to try and conceive naturally when they're ready for it. It doesn't mean they should get pregnant right away. Because again, I have patients who come see me and say, my doctor said not to have surgery until I'm ready to have children. That is not fair because then it means you're going to struggle with symptoms and pain for all those years. And it's going to allow the disease to get worse. It's going to grow deeper into the organs. It's going to get more diffused. So not everybody with endometriosis needs to get pregnant. And I know I've said I focus on fertility because I'm an REI, but
Hmm.
guess what? I did 3 surgeries yesterday, and two of them I did a hysterectomy on. I took out the uterus because they don't want to have children. So not I don't only treat women who want to get pregnant. Endometriosis is a complex disease, and sometimes it involves the uterus, like we said with adenomyosis. And in women who've completed childbearing or who have no interest in getting pregnant, we sometimes will do a hysterectomy as well. So I do treat endometriosis in all its forms, whether women are trying to get pregnant or not, or if they've completed childbearing. I still help them get rid of the disease so that they can have a better quality of life.
Awesome. So there are different types because now you are doing excision surgery. But there are different types of surgery now still in the US. So question here, this is a little bit sensitive question. It can be recurrent because I hear that also is a recurring after surgery. And that's why a lot of surgeons are saying, okay, if you want to have a baby, do your surgery now and then the six
Try
months or
right
one
away.
year
Yeah.
and then try to conceive. That's a very common belief now. And then my question here, honestly asking you, is this can be recurrent? If it can be recurrent again, then what we can do at this time to minimize those recurrence of the endometriosis?
That's a great question. And I'll start by answering the first part about the technique. You're absolutely right. There are different techniques to treatment of endometriosis. There are some doctors who will do ablation of the disease where they burn what they see with their eyes. The problem with that is you're treating the tip of the iceberg. You can only see it a little bit at a time. Endo is deep and goes into the organ. The second problem is you don't have pathology to diagnose endo. I always tell patients I suspect endometriosis based on your symptoms, based on my ultrasound findings, but the only way to confirm and diagnose endometriosis is surgery to excise it. I have to cut it, send it to the pathologist. Pathologist looks under the microscope and says, yes, I see tissue that's similar to the lining of the uterus, that's endometriosis. So surgery is not only to diagnose endo, it's to treat it as well. Ablation is not the gold standard or complete treatment for endo because unfortunately I have to reoperate on a lot of women who've already had surgery for ablation of endometriosis. That doesn't help with their pain. It doesn't get rid of the disease. It doesn't destroy all the inflammatory cells that are in there. And I say this because a lot of these women have a desire to get pregnant. And if there is still endometriosis left that wasn't treated, if the ablation was performed to only treat part of the disease and there's still disease underneath that's inflammatory, it's not going to help substantially improve your chances of pregnancy. You want to have one surgery and you want to have it done right. Because also, if you excise all the disease, the chance of recurrence is a lot smaller. So, back to your recurrence question, yes, endometriosis can recur. But when I see women who tell me they've had surgery every year or they've had surgery 10 times already, there's a big problem there. It's probably that the disease was not appropriately excised in the first place. Because if you truly excise the disease and do what I do, which is a complete peritonectomy, and there's more research now to support that, more data to say that if you strip the entire pelvic covering, remove not just the endospot, but a wide margin around it, you're less likely going to have a recurrence because you're getting rid of all the microscopic cells that may later become endometriosis. So with this excision technique, the risk of recurrence is less than 20%. So if we look at it the other way, there's an 80% chance that this endometriosis is not going to come back. And if it does come back and we need to go in for another surgery, I usually don't find it in the same spots we've excised already. It's usually in unusual locations and weird spots far away from where we've excised it already. Because if you do a complete peritonectomy, it's unlikely going to grow. It's usually spots that were not visible, microscopic, that then responded to hormone stimulation over the years. And so, what I tell patients is if I can give you your quality of life back for the next 5, 6, 7 years, take it. And then if you need to come back for another surgery in 10 years, not a big deal. We'll do another laparoscopy, get rid of the endo, and give you another 10 years of quality of life. We're not talking about surgery every 6 months or every year. Absolutely not. Endo, if it's going to grow back, most data says it'll grow back after at least 5 years. And I do talk to my young patients about that because I operate on 14-year-olds and 15-year-olds, and I tell them, you have another 40 years of periods. You have another 35 years of periods. It may grow back, but if it grows back, we know what to do. We get rid of it. And doing multiple laparoscopies is not going to put you at risk for complications. Laparoscopy has a very low risk of adhesion formation if you do it with an expert, with a surgeon who is high volume, who does this all the time. They
Like
have
you.
really good, like yeah, me and many other
Mhm.
surgeons. There are techniques that we undertake during surgery to reduce the risk of adhesion formation. And we have trained eyes. We can see what's normal and what's abnormal. Because that's the other thing is some doctors pop in a scope and say, everything looked fine. That's not enough. You need to go in, you need to find the disease, you need to cut it out, and you need the pathologist to tell you if there's endo or not. And so, unfortunately, sometimes women come back and say, I'm still in pain. My doctor did my surgery 2 years ago. They didn't find anything. I'm still in pain. Do you think it's worth going in for another surgery? And I always tell them the surgery is not just to say you have endo, it's to help you feel better. And if
Hmm.
that endo was missed on your last surgery, then we didn't really give you a fair chance at recovery because that endo has been there the whole time and was not addressed. So going in for another surgery sometimes is essential. Unfortunately, I don't want to do that, but I've had to go in and reoperate on women who've just had surgery 1 or 2 months ago. And sometimes what happens is the doctor goes in and says, there's a lot of endo. I cannot do anything about it. It's too much. And they close them up and tell them, there's nothing we can do about your endometriosis surgically. You need to go on hormones. They put them on Lupron, which puts them in menopause, shuts down ovarian production, really bad. I have so many stories I can share about, women who've had similar experiences. But just today, I saw a patient who had surgery at age 18 and they went in, didn't know what to expect, and found stage 4, which is the most advanced stage endometriosis. The doctor said I removed what I could and then put her on 6 months of Lupron and 10 years of birth control. So she's 28 years old now, and now she's trying to get pregnant. And she's been trying for a year and is unsuccessful. And she realized, she's a smart girl, she's realized that everything else checks out. Her tubes were deemed open on imaging. Her partner's semen analysis is normal. Her egg count is great. And so she came back to see me to say, or not came back, it's the first time I saw her, but she came back to a gynecologist to see me to say, could I still have endometriosis? I reviewed her operative report. Nothing was done about the stage 4 endo. I scanned her, tons of endo everywhere, still stage 4 endo. And so I told her the disease did not grow. The disease was never removed in the first place. And I feel bad because we
Hmm.
could have done something about it 10 years ago when she was 18 and not have her be in a situation today where she's in pain. She's been trying for a year. She's frustrated. She wants to get pregnant yesterday. And now we have to undo what was not done 10 years ago. So, like I said, sometimes I've had to reoperate on women right away. And my best situation or what I consider best case scenarios when the doctor goes in and says, there's too much, I cannot do it, but let us find you someone who can help you. Let us refer you to a surgeon or a gynecologist who is a specialist in endometriosis or who's a high volume surgeon and knows how to manage stage 4 endometriosis. I think that's the best treatment plan for this patient. Not every doctor can recognize endo, and some people think it's just a simple cyst they're going in to treat or think they're going to find early disease, and that's fine. If they go in surgically and find advanced endo, the best thing they could do is stop and say, I can't do this. Let's find you someone else who can do it for you. And I don't mind going back in a month later, 6 weeks later to treat the disease that was not appropriately treated. And so repeat surgeries happen for whatever
Yeah.
reason, and it's fine, and we do it. And our goal is to help women feel better. And the chances of pain improvement after excision surgery are extremely high. The chances of fertility improving after excision surgery is extremely high. And actually, there's data that I love to quote that support excision surgery in women who have had unsuccessful IVFs. Okay, so women who've had surgery with embryo transfers, they're not getting pregnant. We do surgery, we treat their endometriosis. Guess what? 50% of those women will get pregnant naturally. They don't even
Wow.
need IVF because their primary cause of infertility was endometriosis.
Hmm.
We ignored it. We tried to go around it by doing IVF. It didn't work because there's inflammation in the pelvis. We treated the inflammation, and now guess what? Those women don't even need IVF. They can get pregnant naturally now. Obviously, not everybody's a good candidate for that. Age is the most important
Hmm.
determinant of pregnancy rate. So, women who are younger have a high chance of pregnancy, women who have a normal semen analysis, women who have an open fallopian tubes. But those are all things I check during surgery. So, I check the tubes, I check the ovaries. I typically get a semen analysis beforehand so I can better advise my patients on what our plan is after surgery. So, for example, for this 28-year-old that has a good egg count and her partner's sperm is normal, I don't think she needs IVF. And I told her IVF is not going to go anywhere. If we wait 6 months after surgery, try and get pregnant naturally. If you're not pregnant, we can do IVF then. But if I can save you an IVF cycle, then it means that hopefully you'll be able to get pregnant not just naturally with your first, but also continue to have kids down the line whenever you're ready without having to worry about going through hormone treatment and IVF.
I mean, I'm so glad you are here local, and then so many people can get benefit from you. Also, I hear from the even other IVF doctor that after endometriosis surgery for young people, they actually encourage people to try to conceive naturally. And I'm hearing more and more. And I think it's still a lot of medical society doesn't really understand and then or the value of an endosurgeon, but I think it's rapidly changing and which is exciting. So my burning question for you, because you and I met and then we had a conversation this about birth control pill. You mentioned that for your young patient. And then right now people just put that in the birth control pill like a temporarily. So do you I know you are very upsetting about this approach, right? And then, so what is the, how we can, what is the, this young people? And then if your suggestion is a go to lifestyle change or go for surgery, what is that for young people in the, you're like 18 years old, 19 years old?
Yeah, thank you for bringing that up. I love birth control pills. I have nothing against them for contraception. I think they work great. And if a young couple are not ready to have a child, then going on birth control pill is an excellent option. What really bothers me is when people put women on birth control pills as a treatment plan for endometriosis.
Mm-hmm.
So birth control pills do not treat endometriosis. They're like putting a band-aid on the problem. You have pain because you ovulate, because you're producing all those inflammatory markers that are triggering the endo, then let's stop your ovulation and stop those inflammatory markers from triggering your endo. Okay, great. So while you're on it, you're not ovulating, you're feeling good. But you come off it and we're back to square one. Now you're ovulating. Now those inflammatory markers are triggering your endo because your endo didn't go anywhere. It's always been there. Some women start birth control pills when they're young and they feel great. They feel great for 3, 4, 5 years and then the pain starts to come back. Some women go on birth control pills and they feel terrible and they say, I don't feel better. I feel worse. I have all those mood symptoms. I have all those undesirable side effects from birth control. So birth control pills are not for everyone, but in someone who's young, like I said, 14, 15, who's still in school, they come see me and they say, Doctor, I'm in pain all the time on my period. I tell them, I give them the option of birth control. I do recommend it. I say, do you want to try birth control? Because it can help you feel better until you feel more ready to go to surgery and go through that invasive procedure of having laparoscopy to remove your endo. And I have some girls who say, yes, please, I want to go on it, maybe when I'm in college, and they go on it, they feel good, and then they're fine, they come back when they're ready. And I have women who go on it and they don't feel fine. Or I have girls who say, I don't want to go on birth control pills. Please, I want you to get rid of the disease because it's bothering me physically and mentally. It's affecting me. I can't sleep every night thinking about this disease that's growing inside of me. So there's nothing wrong with going on birth control pills, knowing that that's not going to fix your problem. What bothers me is when women are older at an age where they are very competent to make the choice for surgery, they just were never given the option for surgery. They're told birth control pills, your only treatment plan right now. And you're not ready to have kids today, that's fine. Go on birth control pills. When you're ready, come off birth control and see what happens. But if you already know there's disease, if you've scanned those patients and you see cysts on their ovaries, and by the way, cysts on the ovaries are a sign of deep infiltrative endometriosis. So women who have endometriomas are already advanced stage disease, then they have disease elsewhere. I like to say, I have the saying that I like to repeat, it's never just an endometrioma. Never. You can't just have a cyst on your ovary and nowhere else you have endo. There's always going to be disease elsewhere because by the time that cyst grew and became invasive, all those little implants have grown as well. And so birth control pill has its role in contraception. It has its role in trying to bridge the gap between, being not ready for surgery and waiting until you're ready for surgery, but it should not be offered as a treatment plan for endometriosis. And then you asked about lifestyle. I highly encourage lifestyle changes. That's why I said I will work with all those different specialists. Acupuncture for pelvic pain is amazing. You know more about it than I do. Brings down inflammation, resets the body, helps women feel better. I also recommend pelvic floor physical therapy. I work with all the PTs in the area. And I know, you mentioned, we're fortunate that I'm here. I'm also fortunate that I have other specialists in the area to help me because we have lots of excellent pelvic floor physical therapists. I send my patients for acupuncture all the time because that helps them too. And nutritionist, I have them see a dietitian because going on an anti-inflammatory diet helps. And I have to say, not everywhere do we have specialists like this. I treat women from all over the country. I have patients who fly internationally to have surgery with me because not everybody is able to have this setup. I have made friends in all the different specialties because my patients need that. And we're fortunate to be in an area where specialists are available to help. Not every gynecologist is the same. Not every acupuncturist is the same. Not every physical therapist is the same. So because I've been doing this for a long time, I've found the specialists that are well versed in management of pelvic pain and understand endometriosis, and my patients have had great success working with them. So working with you, Dr. Lee, is an amazing add-on when it comes to fertility because acupuncture for fertility is amazing, but also for pelvic pain. After we treat all the endo and cut it out, I tell my patients your nerves are still very inflamed, your muscles are still very tight, everything in your body is still very, what do we call it, aggravated and activated, and we need something to calm everything down.
Because you said that this is all hormonal inflammation and then immune and then neurological conditions, just very, very combined and then like a complex condition. I think that's why we need a more approach and then not just only one things. So since you are expert in REI as well, and then we also specialize in fertility, you mentioned only way to, I mean, that was my understanding. Only way you can find out this endometriosis is through the surgery. But now I hear people do actually a little bit of biopsy. So I want to ask you about that one because probably you have some question. And this is probably my last question. When people now they want to conceive and they found that they have endometriosis. So what is your advice for these people as well?
That's a great question. That's actually what I spend most of my time talking about in the office is endometriosis and its impact on fertility and fertility treatment and what we should do first, what order of treatment should we have available. The biopsy you mentioned is a very common test in fertility. So in the fertility world, a lot of REs, when they suspect endo, will do this biopsy to check and see if there's inflammatory markers in the uterus that may indicate endometriosis. They look for the BCL6 marker, which is a marker of inflammation. The reason why I don't do those tests and the problem I have with those tests is they have a high false positive and false negative rate. I actually have not seen a false positive, but I have seen so many false negatives, meaning that
Mm.
the patient comes in to see me saying, my doctor did the biopsy and it came back negative, so he says I can't have endometriosis. That's absolutely not true. I cannot tell you how many times I've operated on women with a negative biopsy that have endometriosis. And then I have patients who come see me and say, I have a positive biopsy, but I have zero symptoms of endo. I don't have pain. I don't have pain with my periods. I don't have pain with intercourse. I have infertility because my partner has abnormal sperm. Every single one I've taken to the OR has come back positive for endometriosis. So I have not seen false positives yet. Do they exist? Yes, but the chance of a false positive is a lot smaller. The chance of a false negative is a lot bigger. The reason why I mentioned this is because not everybody with endometriosis needs to have surgery right away. Absolutely not. There has to be a personalized plan, and we have to take into account their ovarian reserve and how many eggs they have on their ovaries. Because what we haven't talked about is unfortunately a lot of women with endometriosis can have a low egg count. So not only do they have disease and pain and inflammation, but they also don't have a lot of eggs on their ovaries. And when we do surgery, especially if we're going to work on the ovary by cutting a cyst out or separating the ovary from its adhesions and attachments, we are going to lose some of those eggs. And for women who have a low egg count to start with, it is probably not a good idea to jump into surgery right away because we're going to lose a lot of those healthy eggs. I would recommend considering egg banking, IVF, to retrieve eggs. If they have partners already, great, we can make embryos. If they don't have partners, we freeze those eggs because we don't want to lose any potential egg we can get. Now, having said that, sometimes the quality of the eggs is low because of the endometriosis around it. Sometimes, even though we think they have a good egg count, we stimulate them, they don't respond as well as they should because the endometriosis is suppressing them. And someone who's had already 2 cycles and they come see me and say, what should I do next? I wouldn't recommend repeating the same thing because it clearly hasn't worked. Then I would say, let's do surgery, remove the endo, and try another IVF cycle after surgery. See if we have better eggs or better outcome. In women who have never tried IVF and they have a low egg count, and we anticipate work on their ovaries, I always recommend egg banking. But in women who have a really good ovarian reserve, and we're not going to do a lot of work on their ovaries, I like to start with the surgery because then if we do IVF, I hope we will get better quality eggs. And we are going to get eggs that are free of endometriosis that will hopefully become better babies. And we may not even need IVF because those patients can get pregnant naturally. So the reason why I'm able to have all those conversations with patients is because I am both their fertility doctor and their surgeon. Sometimes patients see me and they have another fertility doctor. That's absolutely not a problem. We collaborate. I call up the doctor and say, "This is what I'm thinking. What are you thinking?" And we come up with a plan together. But it's important that you think about your fertility. And I'm saying this because you may not be seeing me, you may be seeing another mixed surgeon or another endometriosis specialist that's not a fertility doctor. You should always inquire about your egg count, your ovarian reserve. You should always ask about what surgical techniques are they going to undertake during surgery to save your reproductive organs, because there are steps we can undertake to help reduce the damage to the ovaries, to help open up the fallopian tubes, remove the scarring, and give you the best chance of pregnancy.
That's why, as I said, it's so amazing to have you and then in the two field, which I think are most interesting, like endo and then fertility world together is such a blessing for patients.
And not a lot of patients do what I do. I mean, people do what I do. If you look
No,
at
I don't.
the
I never actually heard.
I think
You are
there's
the
probably
first one.
only 4 or 5 surgeons across the entire country who
Uh-huh.
are endometriosis specialists and fertility specialists. There aren't many of us,
Yeah.
but I think it's an important field. The reason why there aren't many people is it took years of training. I didn't tell you how many years of school I had to go to be where I am today. But I think it's worth it. I would do it again in a heartbeat, and I encourage other physicians and medical students and doctors to also consider a field in very specialized endometriosis care because it is desperately needed. We need
So
more
so
endometriosis
wonderful.
surgeons.
Oh, absolutely. And I mean, actually, I saw more like a growing actually field as well. So anyhow, thank you so much for your precious time. I know you are so busy this morning, and then now you're just you're a super mom and super woman. So can you share with our audience how they can find you, Doc?
Yeah, so I'm all over social media. I hate social media. I just do it because I think that's the best way to raise awareness. So if you're ever interested in hearing more about endometriosis and fertility, you can follow me on Instagram. Dr. Lee can share all my handles, but I'm Dr. Sadiqa Bahbahani. If you just look up my name, I'm at the Center for Endometriosis and Fertility in Newport. You can look it up on Google. I'm on TikTok, new to TikTok. I'm on Facebook and Instagram, and I love to educate. So I teach medical students. I'm also faculty at the UC Riverside, so I teach medical students, I teach residents, and I like to educate the community. So I post a lot about just endometriosis, pelvic pain, fertility. I post surgery videos if anyone's interested in looking at those. And you can always, yeah, reach out to me directly on social media or call the office or email the office if you have any questions or concerns about endometriosis and fertility.
Thank you so much for being available for this time and then for also community as well. And then I truly appreciate it. I'm so honored to talking to you and then discuss this very important topic. Thank you
Of
so
course,
much,
I'm
Doc.
happy to
It
be
was
here.
great.
Thank you, Dr. Lee, for
Thank
inviting
you.
me. Have a great day.